Hi, my name is Janet Gripsover. I'm a nurse practitioner and nurse manager for the liver transplant program at Cedars-Sinai, here to answer some common questions I get about MASH and non-invasive testing. So what happens when you get discordant testing? So let's say you've got a patient who's got a lot of comorbidities and a lot of risk factors for having significant fibrosis in their fatty liver disease. So they've got, diabetes, they've got atherosclerosis, they've got, of course, hyperlipidemia and hypertension, and they've got some abdominal obesity. So, and you get a FIB4 back and it's like right on the edge of probably not having any fibrosis. So you get a FIB4 of like 1.4, which is like just above the cutoff for being normal. And then you get a FibroScan, which is again, another non-invasive test to try to cuff your reading on the FIB4. And that test comes back showing florid cirrhosis. What do you do? Well, that's a really great question because it happens all the time because none of these tests are 100% accurate. So the best thing to do in that case, in my opinion, is to just at that point, you go for the biopsy. Again, I really don't love doing biopsies, but when you need a tiebreaker, that's really the thing that's going to carry water in the end. As they say, the proof is in the pudding. And then that will help you decide what the next step is, especially if cirrhosis is potentially on the table. That might be something to really consider that you really want to rule out right away. Second question is, what is the ideal diet for somebody who has a fatty liver? Well, the very first thing that I would absolutely recommend is that they stay away from alcohol. It's a really low-hanging fruit sometimes. It's a lot easier to completely avoid something than it is to completely change your diet. If somebody has fatty liver disease and they drink routinely, but not enough to really push them into a MASLD, I would still advise them, hey, please stop drinking alcohol. If anything, it'll help with their other comorbidities that likely led them to have fatty liver. They could drop a little bit of weight with it. And again, it helps calm down any kind of inflammation that the liver will have and helps make any kind of diagnostic picture clear, especially if somebody is underreporting how much they're actually drinking. So that's the very first recommendation that I would recommend for somebody with fatty liver disease. After that, I typically recommend anything that will help them to lose weight. So you would want, and typically those diets are going to be your high protein, low fat, lower carb diets. High protein because you want your patients to preserve their lean mass. That will help with their metabolic rate and help with just their robustness and help prevent frailty as they get older. And low fat, because if there is any problems of fat getting through the liver, and again, if you eat fat in your diet, the very first place that anything that you eat will go straight to your liver. And so you want to eat a low fat because you really don't want to throw extra fat on top of a fatty liver. The lower carb diet will help with their comorbidities and also help them with just their general caloric intake and help them lose weight. I do recommend for patients who have fatty liver disease to try to aim for about a 5% weight loss, and that's an overall weight loss. It's usually pretty attainable. If you have a patient that weighs approximately 220, that's talking about 11 pounds. So you tell somebody if they come in and they weigh about 220 pounds, you say, well, you need to try losing about 11 pounds and see how you do. And that seems very attainable for people. They're like, okay, you know what? That's not too bad. I can do that. And it gives them hope and it gives them motivation to make those changes. Generally, I know that when we talk about fatty liver disease, we generally start with diet and exercise, but when do you need to escalate care? When do you need to start thinking about, okay, diet and exercise just isn't working. We need to do something more. Well, I usually give patients about 3 to 6 months to demonstrate some improvement. And if they're not really going anywhere, again, somewhere between 3 and 6 months, depending on when I see them back, especially if there's any indication that they might be having that more aggressive fatty liver disease or that MASH, it's not really so much just fatty liver, they've got that inflammation or that progression there. That's when you need to start thinking about the secondary management. What are you going to do to prevent cirrhosis? Are you going to start them on a medicine to help decrease their chances of developing cirrhosis? Are we going to refer them to bariatric surgery so that they can really get more aggressive about weight loss? Those are the things that we need to think about. Again, and I don't give patients very long because they'll just keep on kicking that can down the road. And even when you introduce that concept of needing to lose weight and with diet and exercise, and you make that first recommendation, patients are still not usually going to take you up on it right away. So I introduced that concept very early. So thank you very much for listening. And if you have any questions, feel free to reach out.